Hey everybody, thanks for coming. I want to shout out to GTF for all they do. They're pulling off a conference in these crazy times, and I got to give them props. So I'm going to spend a little bit of time talking about what's new in lung transplant. And usually when I prepare this talk, I struggle to come up with stuff that's new or novel. This year is a big exception, and for a number of reasons, and we're going to get into it. We got to talk about COVID because it's a lung virus and it affects lung transplant. We're going to talk about other major trends that have happened in transplant and effects on patients, including in the United States, the allocation rules that were changed at the end of 2017. We're going to talk a little bit about EVLP, which stands for ex vivo lung perfusion, which is the lung in the box. We'll talk about hepatitis C, which we now have really, really good treatments for. Usually I don't really talk about immunosuppression because there isn't much coming down the pipeline, but we have moved towards using a kidney transplant medicine in our lung transplant patients. I'm going to talk about CMV monitoring because there's some new testing that we do for that. And we're going to talk about vaccines because everybody always asks me about the shingles vaccine pretty much every clinic visit. And I think you need to have an understanding of what is involved with that. So in basically 12 months ago, there was an outbreak of a novel human coronavirus in Wuhan, China, which has now spread through the rest of the world with major impacts on public health. We now have 10 million people in the United States that have been infected with it, somewhere between 40 to 250,000 confirmed deaths. And it's, the fact that we're just talking virtually right now instead of hanging out at Georgia State speaks to the magnitude of this infection. It is a big deal. And there is a giant race called, warp speed race towards coming up with a treatment for it. And so I want to just give you guys a sense of like what is in the pipeline for coronavirus vaccination. Right now, there are 3 basic types of vaccines that are being developed for coronavirus. One of them is
Okay.
Hey, it's an inactivated vaccine. So basically, a virus that's killed. Another way to do it is to take a different virus, put a piece of the virus in question into that virus, and use that as a delivery system. So that's what a viral vector is. And if you heard of the company AstraZeneca, that's what they're using. So it's a chimpanzee adenovirus that has a piece of coronavirus in it. And then the 2 big clinical trials going on in the United States right now are using something called mRNA, which is it's like a copy of DNA to deliver the genes to make, for a short period of time, pieces of the virus. And that's what the Moderna study and the Pfizer study, which are both in phase 3 clinical trials, that's what they're looking at. And just kind of an interesting side note, I actually am a participant in the Moderna vaccine study. So a couple months ago, I got my first injection of either saline or virus, and then I got another one a month later. And I'll know in about 2 years, because they're going to unblind it, whether or not I got the vaccine or not. But they're simply waiting to have enough people out of 30,000 in those studies to know if they're going to have efficacy. And they defined efficacy as a 50% reduction in virus. And just timelines is, I do think, if I'm being, I may sound a little optimistic, but I do think in the next couple months, we're going to have data on where we are. And so I'm pretty confident we're going to have a vaccine within the next 6 months. And there is an end in sight to this. There's a lot of steps for vaccines to actually become available. So as I said, in the phase 3 studies, you have to have enough cases where you can show that the people that got the vaccine have 50% decrease in virus compared to the people that didn't. The Food and Drug Administration for vaccines, there's two ways that a vaccine gets approved. One is called a BLA, which is a biologic licensing agreement. So like most vaccines have a BLA. That takes 5 years minimum. But the FDA has another way to approve drugs in the short term called a EUA, which is an emergency use authorization. And that's probably what's going to happen first for these vaccines. Then you have to figure out how to make them in large amount. So there's manufacturing questions. They have to ramp up manufacturing. I think for the mRNA vaccines, that'll be relatively quick, but we don't know. You've probably heard that these vaccines need to be stored at very low temperature to stay stable, like -20 to -70 degrees. And so there's a whole distribution question. And then you have to figure out how are we going to follow the people that got vaccinated and make sure that they don't have adverse outcomes, et cetera. So there's a bunch of steps, but I think that we're getting closer and closer. So you could say, well, so what effect has coronavirus or COVID-19 had on transplant volume in the United States? And I think there was this idea that basically we shut down lung transplantation in the US because, we couldn't cope. I will say that at Emory, we had some pretty panic-stricken days towards the end of March, where we saw such an increase in cases that we had to essentially stop everything that was elective for a couple of weeks while we re-engineered our ICUs, we figured out how to cohort patients, et cetera. But that was a short period of time. There's a guy named Luke Benevuto at Columbia who took all of the US data, and he's gone and then mapped the number of transplants that have been done at the major programs compared to the prior 5 years. And the US is just divided into different regions. They're called UNOS regions. And so we are in region 3 with Florida, Alabama, Mississippi, South Carolina, and Puerto Rico and Louisiana. And if you look at this, it actually shows that for our region, at least early on in the pandemic, there wasn't much of a decrease in volume. In fact, if anything, our volumes actually went up a tiny bit. We'll probably end up doing 25 transplants at Emory this year, which is a pretty significant increase for us. But that being said, some other regions in the country saw, a pretty big, hopefully short-term decrease in their transplant volume as they had to, basically go on triage and shut down elective procedures. So that's COVID. I should say before I get into the OPO rule, rules change, you probably have heard that some people that have had COVID or coronavirus infection and have had severe lung failure have been referred for lung transplantation. I will say that is a thing. That is not likely to be something that plays a big impact on a lot of patients because, the sheer number of patients who are sick is overwhelming the total number of transplants that could ever be done. And, in order to do a successful lung transplant on somebody who's in an ICU on either a ventilator or more likely on a heart-lung machine, that person still needs to be awake. They need to be mobile, able to ambulate, and they have to have single organ dysfunction. And so while it is true that people have done lung transplants for coronavirus, it's not likely to be, a major impact on the non-COVID transplant population in general. But you probably have seen news reports about that. The other thing that you need to understand for lung transplant, this is not necessarily a 2020 thing, but I think that its effects are being seen now, is a rule change that UNOS made back in really very, very quickly out of the blue in November of 2017. So, and this came out of a lawsuit filed against Medicare, CMS, by a patient who felt that the rules that were in place at that time disadvantaged patients who were sick on the waiting list, but who didn't have a good chance of getting transplanted. And so this went to federal court, and the judges ruled that, in fact, that the plaintiff was correct, and the way that we were administering allocation at that time was probably not the most faithful reading of what the legislation for organ transplant had been, particularly too long. So prior to 2017, the way that it worked was lungs were allocated locally first, and local meant within your donor service area. So like for Georgia, the donor service area for Georgia is the state of Georgia. So if a lung came up in Georgia, it would get offered to essentially the Emory waiting list before it got offered to anybody else. And you can imagine, like, there could be a lung, say, like in, Dalton, Georgia, down here, and there could be somebody on the waiting list at Nashville and at Vanderbilt who is super duper sick and is going to die within a day or two if they don't get transplanted. But that lung would have gotten offered to Emory before it got offered to Nashville in the old rule, because it got offered locally. What the lawsuit did effectively is it got rid of local donation. So now, instead of having local donation, we have these circles. And the first circle, it's wherever that donor is, that you draw a circle of 250 nautical miles of radius. So 250 nautical miles is like 300 actual miles. And so that circle, any program that's in that circle then becomes the first node for the allocation. Whoever has the highest lung allocation score then becomes primary for that organ. And I think that's probably fair. I mean, I'm not biased against that rule. What I will tell you is that it has created a situation where we have more lungs that are going out of Georgia to be transplanted outside of Georgia than we did previously. And at the same time, there's more lungs from outside of Georgia that we are going to get and bringing them into our state for transplant. So there's a lot more travel that has happened because of this. The other thing that for people that are like on the waiting list for a lung transplant, what this means is, and particularly for our program where we have an aggressive surgeon who wants to look at as many potential organs as possible, is that we've had more dry runs. A dry run is when we call somebody into the hospital, we send a team out to look at the organs inside the chest of the donor and make a decision at that time. And so because we're aggressive, because of the rule change, this has created a situation where, we have to be upfront with our patients to tell them, hey, there's a good chance that you're gonna get called in. I think the record is 5 dry runs for a patient, but there's nothing like the 6th time. So just understand that is a thing that is created in part by the rule change. And there's similar rule changes that have been put into effect for heart transplant and liver transplant. It remains to be seen what the overall impact will be going forward. Similar to this is this idea that maybe we, as a lung transplant community, are not getting enough lungs from the potential donors that are out there. Okay, and so if you think about the total denominator of organ donors, brain dead organ donors, and of that, what percentage of those donors are able to donate lungs, it's only about 15 to 17% of those donors. And the reason is because, when people become brain dead, one of the consequences and the mechanism by which that happens and the consequences of it can damage the lungs. So if you have a motor vehicle accident, you have chest trauma, that can be detrimental to the organs in the chest. If you have a drug overdose, you can aspirate, that can affect the lungs, etc. And so we all recognize that we are probably saying no to some lungs that are actually okay to use. One category of that is a DCD. A DCD is a non-brain dead donor. That is somebody who is brain injured and the family has decided to withdraw care, but organs are not recovered on them until their heart stops. That's not usually how it happens. Another reason that lungs might be turned down is because of time constraints or travel distance. And then the third category would be because they don't look as good as we thought they were, but it's from a young donor, etc. 15 or so years ago, this concept of taking the lungs out of the donor and then putting them on a machine that ventilates the lungs and perfuses the lungs and oxygenates the lungs, that became more and more common. The places that first started doing this in large volume was Toronto General. And right now, I will tell you that about 50%, half of all the lung transplants that are done at Toronto General, which is one of the biggest lung transplant programs in the world, are done using this procedure where you take the lungs out, put them on a machine, recondition them. You use a special preservation solution that may actually draw some of the excess edema fluid out of the lungs. And you can decide before you even make an incision on the recipient whether or not those lungs are good or not. The surgeons love it. And the reason the surgeons love it is because they can, you know, in Toronto, they'll take a lung out and they'll put it on a machine for 16 hours. And so they can, you know, essentially if they get a donor at, you know, midnight, they can take the lungs out, put them on a rig, have a full night's sleep, you know, get up, go to Tim Hortons or whatever they do in Canada, and then do the transplant, you know, at 9 in the morning when everybody's fresh. It's taken a little bit more time in the United States to adopt this for a number of reasons. One of them is that in the United States, the barrier, the cost for programs to go into this is considerably higher. Anytime that program will accept lungs for transplant from an organ procurement organization, if the lungs are used or not used, the program is incurring a cost. And so, and it's not trivial. I mean, there's actually a dollar amount for a pair of lungs. It's kind of mind-boggling, but 2 lungs cost about $80,000. And so one of the things that has happened is policymakers and you know, companies have said, what if we came up with a system where a centralized hospital takes the lungs and reconditions them and then offers them out to whoever would accept them. And so there is such a company. That company is called Lung Bioengineering, LBE. They have a very nice website. It's really kind of a success story. That company was started by this eccentric woman who founded Sirius Satellite Radio. And what they've done is they've put together 2 hospitals. One is in Bethesda, Maryland. The other is in Jacksonville, Florida. And these hospitals, they exist just for organ recovery. So an organ that we think might not be perfect or we're not sure about, or there's time constraints, LBE takes it to their program, and then they have 6 hours to recondition it. And if it's good, then they'll ship it to the transplant center. Emory is one of 16 programs in the country that is in a clinical trial with LBE, Lung Bioengineering. And so the reason it's a clinical trial is this is really a feasibility study to ask the question, can a third party successfully resuscitate lungs? And so far we've done a couple transplants through this clinical trial. They're trying to get 75 patients in the control arm and 75 patients in the regular arm to see if it has success. I think this is going to completely be the way that lung transplant happens in the United States going forward. But stay tuned to that. As I said, there's a ton of data out of Canada looking at EVLP, and this is from a paper that looks at the survival of patients who are transplanted either by conventional ways, so you just take out the lungs, put them in ice, transport them, and then sew them in, or EVLP, which is you take out the lungs, put them on the machine, reconfigure them, and then transplant them. And what this shows is that the long-term outcomes in this is a very large number of patients in Toronto, is essentially exactly the same. There's no difference in survival. So that's encouraging. So that's EVLP, and I think you should pay close attention to that space. Another thing that we've done really, and it's been quite surprising to me in the past year, is we've really changed the way we think about donors who may have previously we've said no to. And one of the biggest categories of that is hepatitis C. Hepatitis C is a chronic infection of the liver. It's actually a reason that people end up getting liver transplants. But many people have hepatitis C, do not know it, and are completely asymptomatic. A lot of times we screen donors every time we screen donors, and they'll pop up positive for hepatitis C. And traditionally, we've said, well, we're not going to take the lungs from that donor, because if we do, there's a really good chance that our recipient will develop hepatitis C, and that's a no-no. In the 90s, the treatment for hepatitis C was about 50% effective. In the early 2000s, newer medications like interferon came into the market, and the efficacy of those medicines went up to about 70%. About 10 years ago, a new class of medicines called the direct-acting antiretrovirals were introduced, which improved the cure rates to about 90%. And today, and if you watch television, you've seen these commercials, there are two medications on the market, Mavyret and Epclusa, who now have a cure rate in between 98 and 100%. Basically, we have cured hepatitis C in the US. And the benefit of these drugs is they're short courses. You either take them for about 8 weeks or 12 weeks. And if you have hepatitis C, it's gone. So what we started doing in liver transplant is we started taking hepatitis C liver donors, transplanting their liver, and then putting people at the time of transplant on these direct-acting antiretroviral therapies, and it completely worked. And so we started doing it in kidney, and it completely worked. And so last year we said, hey, we've got to start doing this in lung transplant. And we've done, I don't know, 5 or 6 of these, and it's completely worked. And we've had nobody has converted hepatitis C in the aftermath of a transplant. Obviously, we're going to be selective about which donors to take. We're not going to take a donor who's old, who has emphysema and has hep C. These are lungs from donors who are otherwise perfect. But I think, we started doing this almost as a stretch goal. And now I think it's pretty much standard of care. If you're not accepting hepatitis C lungs, you're probably missing a big pool. Let's switch gears a little bit and talk about meds. People always ask me what's coming down the pipeline. Most people, I think, on this call will recognize that lung transplant is, to some extent, the redheaded stepchild of organ transplant. There are very few medicines that actually have an FDA indication in lung transplant. Really, valganciclovir, which we'll talk about in a sec, is probably the only one that has an actual FDA indication. So almost everything that we use is off-label. So this is a non-indicated use, but of course, we have to use something. And the approvals, these indications come from liver and kidney transplant. Traditionally, the big medicines that we've used that are the workhorse in transplant is tacrolimus and cyclosporin. Tacrolimus is Prograf, cyclosporin is Gengraf or Neujahr, and then everybody gets azathioprine or mycophenolate, Imuran or Cellcept. But everybody basically needs to be on one of tacrolimus or cyclosporin at the beginning of transplant. But what's the big problem with those medicines is that they have a lot of side effects, a lot of off-target side effects. And so I think about tacrolimus and cyclosporin as a kidney transplant drug that causes eventually kidney failure. And we see that. And I will tell you that, we have a cohort of patients who are 15 and 20 years out from their lung transplants. Pretty much every single one of those patients has some degree of kidney failure. Some of those patients are on dialysis. Some have actually gotten kidney transplants. So it's a big problem. And so we've been looking for ways to mitigate that risk. About, 15 years ago, the pivotal trial for a medicine for kidney transplant was done. It turns out, I'm just going to show you this little cartoon down here. So the primary white blood cell that we care about in organ transplant is this cell called a T cell. And the T cell has a receptor on its surface that sees the donor proteins. And so the donor proteins are presented on something called an APC, an antigen presenting cell. So it's like a lock and the key. The T cell sees the proteins and says, oh, this is bad, I'm gonna kill it. But the T cell needs something more than just that receptor. It needs a second signal, it needs a little boost to get it going. And there's other receptors on the surface of the T cell which have to engage with the helper molecules on the antigen presenting cell. And so there's a kidney transplant medicine now called belatacept. It was first called LEA29Y. It's also, belatacept is marketed as Neujahr. And what the pivotal study in kidney transplant showed was that you could, instead of giving patients cyclosporin or tacrolimus, you could give them belatacept, and then the other two less toxic medicines. And the patients had improved kidney function compared to the patients that were treated with cyclosporin. And not only that, they had less diabetes, their blood pressure was under better control. And so this is pretty much I'm not going to say it's the standard of care in kidney transplant, but we take care of a lot of patients with kidney transplants who get belatacept. It's not indicated in lung transplant. That being said, we have started to roll out a protocol. We've treated a couple of patients now with belatacept in lung transplant. And the way that I think it's going to work is that we're not going to get rid of the tacrolimus. But what we are going to do is instead of giving very high doses of tacrolimus, particularly for people who have marginal kidney function, we'll actually give them we'll set a lower target trough level, and then we'll use belatacept as an infusion once a month to come in behind it to sort of cover that gap, if you will. And there are some complicated issues associated with the use of it. You cannot use it in people that have a history of lymphoma. We care about this virus called CMV because we think that we can reactivate CMV with the use of belatacept. And then the third issue is just a logistics and insurance issue. This drug was rolled out in kidney transplant. You guys may remember that there was a massive hurricane that hit Puerto Rico, Hurricane Maria, and that took out a gigantic production center that Bristol Myers was rolling out to increase belatacept for kidney. They have finally got that factory online. So there's a period of time where we couldn't even get this for our kidney transplant patients. Now we're able to get enough drug for everybody, but insurance, getting it approved by insurance is still an issue. And I think probably the most gratifying part of my job is to call insurance companies and beg for stuff, but that's really has been I'm joking about that. That's been my reality with this, but stay tuned. I think this is going to become a real thing. The other kind of cool thing that's come down the pipeline is this virus monitoring that we've started to use for CMV. CMV is cytomegalovirus. I hate CMV. CMV is the troll of lung transplant. So what is CMV? CMV is this virus. It's in the herpes virus family. It's similar to chicken pox. It's similar to Epstein-Barr virus, which causes mono. And most people have it. Most people have been infected with it by the time they hit 18, all right? Like 80%, sometimes 90%. And what happens is you get an infection with it, your immune system takes care of it, and then it lies dormant in your body basically forever. And unless you have a suppressed immune system, no big deal. It's never going to come back. But when we suppress the immune system, the CMV that's established latency in the person can come back out, can start replicating, and can cause infections. And the big places that it causes infections is the lung. It can also cause colitis, which is an infection of the colon. And so what ends up happening is when we do a lung transplant, if you've been infected with CMV, you have it in your body, you need to be on medication to prevent it from recurring. The highest risk is early on after transplant. If you don't have CMV, so if you're in that 20% of people that has never been infected with CMV and your donor had it, then you're actually at very high risk of having CMV infection. And those patients need to be on medications for at least a minimum of 12 months. And what we do, so if you're not a mismatch, you've had CMV before and you get a lung, we put people on valganciclovir for 6 months. And then at 6 months, if the virus in your blood is 0, we take the valganciclovir away. And then every month, or even more frequently, we'll test your blood to see if the CMV comes back. It's a very inartful, empiric approach to monitoring. And then the problem is that if it comes back, then you have to go back on the valganciclovir. And so you might say, well, why do you stop the valganciclovir? Like, why not just keep people on valganciclovir forever? And there's a lot of reasons for that. I mean, if you're taking 15 medicines, you don't want to take a 16th medicine. It has some costs associated with it. And valganciclovir has side effects. It suppresses your bone marrow. It may make you more anemic. make your platelets low. So anything that we can do to reduce that is beneficial. So the real question that we want to know, or we've always wanted to know, is how do we know which patients we can stop that valsite at, say, 6 months, or which patients that we can stop that valsite at 12 months and know that we're going to be okay? And up until now, there was no way to do it. But there's a new test that's come into the market a couple of years ago it's called Viracor. And it actually works by the same principle that the testing that we now do testing for people with tuberculosis. And so what you do is we take blood from our recipients. And the way that we're doing this right now is we're looking at everybody at 12 months who is a mismatch. So we take their blood out, and then their blood gets mixed with some CMV. And we then, so again, back to the T cells, my favorite cell. So we incubate the T cells with CMV peptides, and they get incubated for about 16 to 24 hours. And then we look at those cells and ask the question, are they producing this antivirus molecule called gamma interferon, which you've probably heard about? And if the answer to that is yes, then we say, okay, if we stop the valganciclovir, they're probably going to be okay. And that's what we do. But if at 12 months you were CMV negative, you got a CMV positive donor, and we do the test and you don't make gamma interferon, I'm not going to stop your valsite. You're basically on valsite for forever. But and you say, well, that sucks. But what would be worse than that is for us to stop the valsite, have the CMV come back, and now you can have a real problem where you can get a resistant virus that's no longer sensitive to valsite. And so this has been our new approach as of about 12 months ago. I spent a little bit of time about vaccines, and then we'll move to questions. So, if anybody who's been in the clinic knows that in the clinic room, there's this big poster, and it talks about vaccinations, and there's a green and a red, and the green has all the vaccines that are safe in transplant, the red has all the things that are not safe. The unsafe vaccines are generally the live attenuated vaccines. So like oral polio, for example, which people don't get anymore, but that's a good example of a live attenuated vaccine. Should not be given to an organ transplant patient because they could get, virus replication. For the case of shingles, shingles is a reactivated varicella. It's reactivated chickenpox. The old vaccine that we used for shingles was Zostavax, and it was a live varicella. And the issue with Zostavax is that in an immunosuppressed patient, if you give that vaccine, they can reactivate and they can have disseminated zoster, which can make them quite ill. And it's not just a hypothetical. I mean, we actually did a trial in kidney transplants and patients that weren't on that much immunosuppression, and a few of those patients actually got very, very sick. The good news is that there is now on the market, it's been on the market for a couple of years, but we didn't know how to use it in organ transplant, a vaccine for varicella, which is a booster vaccine, which is not a live attenuated virus. It is a subunit vaccine. So you cannot get varicella from this vaccination. We were always concerned about using this in organ transplant patients, and the concern that we had the name of the vaccine is Shingrix. Our concern was that it might, even though it wasn't going to give you a varicella infection, that it might trigger your immune system and cause you to have an increased risk of rejection. Well, here's the good news. We did a bunch of studies in kidney transplants patients. They were the guinea pigs in this case, and virtually nobody had any ill effects from the Shingrix vaccination. The other thing that we noticed is that in a few patients, when we looked in their blood before and after vaccination, in a few patients, there was a temporary blip up in antibodies against their donor in the Shingrix population. And so the way that we have rolled this out for lung transplant is we have said, if you would like to be vaccinated for shingles, that's fine. The way that we do it is before we give you the vaccine, and it's 2 doses, we will draw your blood and see if you have any antibodies in your blood to your donor. That's our baseline. Then we give you the first shot. Then we check your blood again to see if you have antibodies to your donor. If you don't, we give you the next shot, and after the second shot, we'll check you again. So that's the protocol. It sounds a little bit cumbersome, but I think it's okay for it to be cumbersome because that's how we're going to give it safely. But just understand that it takes a little bit of coordination to do that, but that's how we're doing it now. Do not forget the other vaccines, though. I hope everybody here has been vaccinated for influenza, seasonal influenza. I hope that everybody who's over 65 has gotten the high-dose influenza vaccination. And then we also recommend for our lung patients pneumococcal vaccination, pneumococcal pneumonia vaccination. And there's 2 vaccines that you need to know about. One is called Prevnar 13, and it is the stronger vaccine that covers only 13 serotypes. And then there's Pneumovax 23, which is a slightly weaker vaccine, but has broader coverage over 23 serotypes of pneumococcal pneumonia. The way that this works is you get Prevnar 13 just every 5 years, and then once after 65. And then within 6 to 12 months of the Prevnar 13 vaccination, you get that followed up with a Pneumovax 23 vaccination, the original Pneumovax. So make sure that we're getting those vaccines. All right, so what's my summary? COVID, not a hoax. It's a big deal. We've actually had a fair number of lung transplant patients come down with COVID, and knock on wood, they've done okay. But it's something to take seriously. Ex vivo lung perfusion is a thing. It's going to take over the United States, I hope, and it's really going to increase the number of people we transplant. There's some new drugs on the horizon that I think they're mostly protective of your kidney function, which is awesome. We have a new tool for CMV monitoring, which is also going to change the field. And then I talked about the shingles vaccine, which requires lots of steps. So that's all I got. So what can I tell? Who has questions?
I have a question, if I may. Can everyone hear me?
Yeah, who is that?
This is Wills. I have my video disabled because I'm kind of working on some other stuff. But I'm actually a liver recipient, and I attended the TNT conference last year and attended the liver, but wanted to kind of venture out a little bit and see what else is being said. So that's why I'm in here. But my question is, as far as from the lung aspect, you provide a lot of great information about COVID and how it impacts that. Have you heard anything with working, with other folks in your department or maybe across other departments out there with liver or in other organs that, y'all are seeing carryover effects from COVID of folks who are getting it? And how it impacts their liver and lungs, or is there one or the other that y'all are more concerned about?
You mean of which organ?
Yes, sir.
Oh, definitely the lungs.
Okay.
Yeah. So COVID is a lung infection. It's tropism for the lungs. The 2 organ systems that we really care about with COVID are going to be your lungs and your cardiovascular system. Like it causes endothelial dysfunction. Endothelium is the lining of your blood vessels. And so the other thing that we kind of didn't appreciate early on in the pandemic, but is that if you get very sick with COVID, if you get sick enough to be hospitalized, you have a high chance of developing a blood clot. And so, it can affect any body system. I mean, it's in pediatrics, it causes this syndrome that looks like a vasculitis, a blood vessel inflammation disorder called Kawasaki's disease. It can affect the brain. It can give you, the smell issues and the taste, but there's some neurotoxicity from it. Kidney dysfunction. Back in March when we had kind of an all hands on deck moment at Emory, we were within a couple cases of having to ration our CRRT machines, which is our dialysis machines, but we didn't get to that point. So, but yeah, it can affect everything, but the big one would be the lungs. And that's not just me being biased.
Okay, awesome. Thank you for that information. I was just wondering because when it started, I was I was intrigued on what all it was going to mean as far as across the spectrum for different organs, and what all people were going to be seeing as far as the impact. So thank you for answering that question. I really appreciate it.
Yeah, I mean, I think there's other stuff that we don't know that's pertinent to organ transplant and COVID. So, like for lung transplant, we have this thing called chronic rejection or bronchiolitis obliterans. So put the lung in, works great, and then 5 years later, all of a sudden the wheels come off and the lung function starts to decline. That's an example. And one of the inputs for that, one of the things that can trigger that is viral infection. And so it's not that uncommon for somebody to get like influenza virus infection or respiratory syncytial virus, RSV, which is the stupid virus that you get from kids. But in an organ transplant patient, it can be bad. Or CMV infection, for example. It's not uncommon for people to have that, and then all of a sudden, somebody who's super stable goes into this rapid chronic rejection phase. We don't know if that's going to happen for corona. We just don't have enough time. So we just have to keep our eye on it.
Hey, Dr. Neujahr.
Hey. There's more of a comment then, huh? We lost him.
Sorry, man. It threw itself on mute. Question for you. When the COVID vaccine comes out,
yeah, should
transplant patients sign up first or be early in line to get it? Or are we better off to wait a little bit just to see what the market, how things pan out?
I don't think that you're going to have to decide that. I think that I think the rollout itself will decide that. So for a couple things. Number one, so the AstraZeneca Chadox virus, we shouldn't use for organ transplant patients at all, because that's a live virus, right? And that AstraZeneca, they have European data, and they actually may have a European approval for that in December. That will take 6 months, 12 months to have enough vaccinations to get into the US market. So that's not like a thing right now, but that's pretty much off limits because it's a live virus. The Moderna and Pfizer platforms, which are the mRNA nanoparticle platforms, are going to go through the EUA process in the US, Emergency Use Authorization process. So this is way inside baseball, but if you really want to geek out and watch a good webcast, there is a group, the FDA has an advisory group called VRBPAC, VRBPAC, and it's like Vaccines, Recombinants, Biological something Action Committee. The federal employees, all of their stuff is live streamed, and then you can go and look at it in the archive. The VRBPAC meeting from late October really kind of gives you a good idea of how it's likely to happen in the United States. We're going to have a very narrow EUA. It's going to be only for adults. It's going to be only people who are healthy, and this is the first rollout. And it's probably going to go to frontline workers, healthcare workers, nurses, doctors, first responders first. I think it's going to take a while for it to get into the general population. And that's just because, the safety data, all the safety studies are done in people that are pretty healthy. By design, you don't want to roll out a vaccine trial and then have a lot of adverse outcomes that you have to kind of make. So, Rich, I'll tell you when you can get it, but it's not going to be. Your spouses, your family members are going to get it before anybody that has an organ transplant gets it. It's just how it is.
Okay. All right. I appreciate that.
Yeah. You sound good.
Yeah, I feel good too. Thank you.
Hey, Dr. Neujahr.
Hmm.
With the cold and the flu, with the cold season coming around also, when should we be concerned if it's COVID?
It's a great question. You know, I think that we have to be super, super vigilant about this stuff. And, you know, for all the lung transplant patients, if you feel like if there's a potential that you have coronavirus, call us. We are running our screening center at North Lake Mall, 6 days a week. We can get you in and get screened. That test has a turnaround of 24 hours, usually. Sometimes it's less than that. But it's not like the flu where I would give you Tamiflu and I have something that I can really hang my hat on as an outpatient. So the reason to know if you have coronavirus is so that you can self-quarantine and just be ready if you get sick to come into the hospital. Hospitalized patients, we have more stuff that we can use in the hospital. Right now, what's doing the heavy lifting for the hospitalized patients are steroids, which people are already on, but we use dexamethasone or hydrocortisone, blood thinners for people that have indices that indicate that their clotting may be out of whack, and then this medicine called remdesivir. But the real reason to know if you have an infection is so that you can be prepared in case you get worse. I think we've had 15 or so lung transplant patients that have had COVID, if my memory serves. We've had 2 people get hospitalized, and they both got discharged. So it hasn't been terrible, but the numbers are small. But just be vigilant, if you have symptoms,
Okay, I was just asking because I woke up kind of with a runny nose and things, so that's why I was asking.
Yeah, I mean, I woke up with a runny nose too. Rhinitis, by the way, a runny nose is actually not that big of a warning flag. The big ones would be a fever, a non-productive cough, a fever, loss of taste and loss of smell are very specific for COVID. But I would expect with the seasons changing and, we still have a lot of mold that, people are going to have a lot of rhinitis, which is non-specific. And then we're still seeing rhinovirus in the community. So, but yeah, basically call, send your coordinator a portal message. We'll get you in, we'll get you screened. If you just have a runny nose, I wouldn't do anything about it. What else you guys want to know?
Hey, Dr. Neujahr. I had a couple of questions. I missed, so forgive me if I butcher this, but with the shingles vaccine, you were saying it's okay to use, but for Emory, is that standard or is it just like targeting a certain demographic?
No, I would vaccinate anybody who has an organ transplant yeah, it's pretty standard. It's just, I want you to know that it's going to be 3 blood draws. Because, right? Because what we don't want to have happen is we don't want to miss. There is a theoretical, and I think it's pretty small, but we saw some signal of this in kidney transplant. There's a theoretical risk of unmasking some antibody responses to your donor with the vaccine. So the vaccine, the way that the vaccine works is there's a piece of varicella in there, and then the manufacturer puts in something called an adjuvant. An adjuvant is a chemical that turns your immune system on. And most of what we try to do in organ transplant is keep the immune system on the down low. So when we did it in kidney transplant, what we saw is, 10%, 15% of patients had a small blip in their antibodies they went from 0 to detectable antibodies to their donor. We've not seen this in lung transplant, just so you know. And so it's really a theoretical risk. I think probably that is going to be mostly people that mostly women who had children before transplant, so they had some pre-existing antibodies to other people, and that is just unmasking those things. If we're being completely honest, there's sometimes we give flu vaccinations and see that as well. So, but we're not going to do that for flu shot because that would be completely impractical. But for the shingles, that's how we're rolling out the protocol. If in like 5 years we just say, hey, we looked at the data and there's like insignificant change, then we'll probably just give it to you. But so you can get vaccinated. I just want you to know you're getting 3 blood draws if you do.
Okay, so right now it is protocol for Emory.
I mean protocol, yeah, it's part of the Emory Transplant Center protocol.
Okay.
But I don't say it's not protocol in the sense that like flu is, you got to get it. Like you got to have a pretty damn good reason not to get it. And we try to vaccinate 100% of flu. The shingles vaccination it would be almost unheard of for somebody to die of shingles. Okay. And not for a number of reasons. Number one, we can, if they have disseminated zoster, we can pull back on the immunosuppression, they'll be fine. The second is we have drugs for it that work, like Valtrex, valacyclovir, acyclovir will cure it. And so how do I say this? So the downside of shingles is much less than the downside of dying from influenza, if that makes sense.
Yeah.
And so really you don't want to get shingles because it's a huge pain in the ass, or pain in the wherever you get it. I mean, it hurts, makes you feel bad. And you can have, even once it's gone, it can doink your nerves, and then you can have post-herpetic neuralgia, like even after the virus is gone. So it's a lifestyle, it screws up but it's not life-threatening in the same way that flu would be. So we have a protocol to give it, but I don't tell people they have to get shingles. I say, if you want to get the vaccine, I'll vaccinate you for it.
Gotcha. And then on the CMV real quick, so you're trying this new process of taking the blood samples and testing for the reactivity or non-reactivity for CMV.
Yeah.
Are you, and if there is no antibody reaction, I guess you're saying, okay, you're going to get the patients back on the Val site. Are you, or is the Emory program looking to do that like retroactively for past patients, or is this just going forward?
I think we do it going forward. So if you got Valcyte, and I don't know your donor and recipient match, but like, let's say you were a mismatch. It means you didn't have CMV and your donor did. So that's the high risk. And then you took 12 months of Valcyte, and then they stopped it and you didn't get CMV. Well, then that's great. That's the old way we used to do it. But I don't think there's a reason to then go test you and see if you have reactivity, because if you didn't reactivate within a month after coming off the Valcyte, then you're not going to reactivate, if that makes sense.
Gotcha.
So it's not practical, because I'm not going to look at a bunch of people and who are doing fine with no virus in their blood and do a test and then go, well, you didn't have a good T cell response, so we should put you back on this antiviral that you haven't needed for a few years. That doesn't make a lot of sense to me. What we're trying to do is get rid of medicines, not add on medicines. But for people that are, and I'm sure there are people in the audience who've experienced this, we have seen cases where it's a mismatch, or maybe not a mismatch, and we've stopped the antivirus medicines. The CMVs come back, and oh crap, it's now valganciclovir, Valcyte resistant CMV. And now your options are like IV ganciclovir, foscarnet plus, like everything that we add on now is going to be not a pill, and because it's going to need a lot of monitoring. So. I think the utility of the T cell, and we're not looking at antibodies, we're looking at gamma interferon production, but same idea. I think the utility of that assay is really for the high risk people to know when they can come off, and just recognize that probably 50% of people that are mismatches are going to need to be on Valgan cyclovir forever. It's
Okay. And then last question for you. You were talking earlier about the ex vivo perfusion.
yeah.
And, you know, I sat in on an ESOP presentation earlier in the summer where Toronto was talking about that. But that, if I remember correctly, because I don't recall exactly, but they were even talking about, in addition to the ex vivo perfusion, maybe even looking to further manipulate young lungs for use in the future. Is Emory involved in any of that, looking at any of that? And is that something that you guys talk over with the prospective recipient about, or no?
Yeah, I don't know that Toronto is, are you talking about like their gene therapy stuff?
Yeah, yeah.
Yeah, so what Calvin's talking about is that has not been, no, I don't think that's been done in humans yet. Like they've done gene delivery. So when you have the lungs outside of the body, what he's saying is at that point you have the potential to add other stuff. And one of the things that you could add is you could put in a gene that that reduces the immunogenicity, the sort of the immune response of the lung to the donor, to the recipient. And there's a cytokine called IL-10 that the Toronto group has shown that they can, you know, turn on and produce in high levels, and that seems to chill out the immune system. There are other things that people have looked at. They've looked at like taking this stuff called mesenchymal stromal cells, which are like a type of, not really stem cells, but they're like a stem cell, putting them in the perfusate, the juice that's going through the lungs, and we think those stem cells or whatever, some factor that the stem cells may make the lungs hardier in some way or fashion. These are all good ideas that may bear fruit in the future, but right now it's preclinical in the sense that they're looking at either lungs that are discarded to see if they can show feasibility on the pump, or they're using it as part of an animal model.
Right.
It'll be interesting to see if that has legs, you know, but yeah, Emory is not at that point where we can start doing that in people yet. I think that's pretty far off.
Right. Yeah, I think I remember them saying something about it along the lines of, you know, all this like Star Trek stuff kind of coming down the line. But I guess I was talking more specifically to the trials with the ex vivo perfusion and the potential recipient. On the recipient side, do they know anything about that, or is that just, you know, potential? Is that just something that they know about, or the transplant team knows about only? You know, you were talking about the trials with the two different hospitals that do the ex vivo.
Yeah. So I'm sorry. Can you repeat the question a bit?
Would there be any additional education or information that the potential recipient, that Emory would share with the potential recipient for, I guess, normally sourced lungs versus the ex vivo perfusion lungs?
Oh, like what we disclose to the patient?
Yeah.
Well, I mean, everybody that is right now, if you're in a third-party ex vivo situation, that's part of a clinical trial, and so that, yeah, that. Gotcha. We do informed consent. Actually, the organ recovery costs are all borne by the sponsor right now because it's a clinical trial. I think that company is looking to get approval so that they can become, you know, like a distribution center, if you will, for lungs. And I don't know, I mean, we're obviously going to have to do a lot of education on our end for our recipients to say, hey, you know, once this is going to get approved, I mean, it makes sense. And it really doesn't make sense for medium-sized programs to have their own in-house ex vivo for the financial reasons I said. So this will get this will become, I think, the way that it's usually done, at least in the United States. But I think we're going to have to work on like how we explain this to people. Like, you know, it used to be there was one way to get a lung transplant. There's a brain dead donor, and we're going to go get the lungs, pack them in ice, and bring them over. Now there's like 5 ways. You know, you can have, you know, a person that's not brain dead, and then we bring them over, and that not brain dead, and put them on a machine, or brain dead with, you know. So we're going to have to do a lot more education with our patients to explain, you know, where do donors come from moving forward.
All right, appreciate it.
Thanks. You look great.
Hey man, you still running?
Yeah. Are you still running?
Not since March. I got some pretty bad plantar fasciitis and had to lay off for a little bit. So yeah, kind of sucks.
Yeah. Well, you got to do something. Who else wants to know stuff? Or should we wrap it up? Well, listen, guys. You know where to reach me. This is recorded. I want to, again, give a shout out to George Transplant Foundation. I think they're doing an amazing job. And it was just super nice to be able to today and give you my take. And, you know, things are going to be okay. And next year we'll probably meet in person.
All righty. On behalf of GTF, I want to thank Dr. Neujahr for taking his time to speak to us today. A quick reminder to everyone that the email will come to you tomorrow with a quick survey, and we are counting on you to take a few minutes to complete this so that we can improve our conferences for 2021. Thank you for coming out today, and please always reach out to GTF if you have any questions or needs along your transplant journey.
All right, guys, take care.
Thank you all.